Common lesions that we can miss, and we really have to make a correct diagnosis to be able to have proper management. I'm Professor Ihab Saadman. I'm from Egypt, and I'm really pleased to be here. And I would thank definitely the organizing committee for giving me that chance. We have a laser pointer there, pointed at the person who is living now. So it's why is leukocoria important? Really, we have to make the distinction and the differential diagnosis of all lesions. Because by simply making a simple decision of I will go and do surgery for one of those kids who presented with the same condition. They're presented with leukocoria, they are of the same age, and one eye has something that is wrong in the back of the eye. So by starting by doing surgery in one of those kids that would have the CT showing a pathology in the eye, in the left eye here, and so showing some retinal changes, probably maybe I don't know calcification or not, or maybe a mass. So by doing surgery in one patient here, if we decide to open the eye, we will simply kill the patient in 6 months' time. And we are not murderers, remember that. So we can lose an eye from expulsive hemorrhage, but we cannot bear on our consciousness to kill a patient because we misdiagnosed her. This young lady has retinoblastoma. This gentleman had a form of posterior fetal vasculature or anything that is repairable. So we have to make a distinction if we'd like to do a vitrectomy for this guy and to differentiate from retinoblastoma for the other patient as well. Remember also the principle of shifting fluid. So this patient came and he had the vodka nagrada and he was sitting. You see the bullous detachment, and that is convex anteriorly. And when he stands up, this is the lying position. When he stands up, the fluid goes inferiorly. So this is a very simple way to show off the shifting fluid. And we can know this by asking the patient a very simple question. What's your vision when you wake up, when you're in the morning? So he will have a blurred vision from the supine position, and then when after some times, the fluid will shift inferiorly. So this is a very nice demonstration of the principle of shifting fluid. So if we have a patient with leukocoria, after this hour, you should be 80% sure of making the diagnosis of retinoblastoma, and maybe 20% uncertain about the differential diagnosis, which is really, really important. Comes on top of the differential, the Coats disease, the persistent fetal vasculature, the toxocara, and a whole lot of other pathologies. The one thing you have to remember about Coats disease is telangiectasia. And by definition, the telangiectatic vessels dilate and then constrict and then dilate and then constrict. So this is the only one thing that you really have to look very thoroughly and very carefully at. If we don't find telangiectasia, we're very much in trouble. Remember also that tumor vasculatures go into the tumor and grows exponentially larger as it feeds the tumor. And this is a huge difference between Coats and retinoblastoma. So the retinal telangiectasia is in essence exudation and detachment. We have a whole lot of exudation under the retina, and also the capillary blood perfusion is really important. I'd like you to refer to this paper published in the BGO in 2009, which is the way of dealing with stage 2, 3, and maybe 4 Coats disease. But this is an important paper that is now the standard of care of patients with Coats disease. So we're having an exudative detachment, lipid deposition, a grayish nodule that mimics retinoblastoma mass, usually in the macular area, that proves to be a choroidal neovascular membrane, and then the cholesterol crystals within the Coats disease. Also, the reflex here, as you can see, is not leukocoria, it's more like xanthocoria. This is a yellowish pupillary reflex rather than whitish pupillary reflex. This mass, which is a choroidal neovascular membrane at the macula, has a high internal reflectivity, and the echoes are really high. This is a fibrosed choroidal neovascular membrane that can mimic calcific retinoblastoma. So the management, as you can see, is to make a diagnosis, exudation, macular exudation, and exudative detachment. And if you look at the periphery, you can see the choroidal ischemia and the dilatation, constriction of the vessels, and we have to quantify the dilated vessels in each quadrant. So the management is, if you have a detachment that goes beyond 6 millimeters from the retina, you don't try to do laser because you can injure and induce a retinal break. What you can do is inject. At the time we injected triamcinolone, initially they were 4 milligram, then we discovered that cataract will ensue in a year time, so we went down to 2 milligram, and a whole kind of anti-VEGF were injected, and papers came after this paper in the literature. The target of the Tiracord is to dry up the retina, which happens usually in 3 to 4 weeks time, and then we can come back and do the laser ablation to the ischemic retinal periphery, and this will maintain and preserve the eye for a long time. What about stage 3 to 4 Coats disease, where we have an advanced retinal detachment that comes close to the retina? Again, we have to make sure that the vessels are telangiectatic, they dilate and constrict, and dilate and constrict. And by doing a fluorescein angiography, you can see the ischemia at the very far periphery. The typical management is, again, to make sure one more time in the OR before any surgical decision that this is not a malignancy, this is not a mass. And we look thoroughly at the periphery to identify one more time the telangiectasia, which you can appreciate in the quadrants here. And we really take our time because we can always change the decision. Never be one-track minded. Always have the flexibility of re-questioning yourself before doing any surgery that can compromise the life of the patient. So this is telangiectasia. So this is not retinoblastoma. And we demonstrate clearly at the very far periphery the telangiectatic vessel. So we think of the entity as an exudative detachment. So it's like a glaucoma, but it pours the fluid on the subretinal space. What we do is we identify and isolate the infratemporal quadrant, and we remove about 90% flap of the sclera, 1 by 1 centimeter. The thickness is 90%. We leave just a little bit of sclera and the choroid underneath, and we just amputate that flap completely. If you can think about a non-penetrating glaucoma surgery, this is the way we think about it. We insert an anterior chamber infusion, and we open the 10% left of the sclera with a 27 gauge cannula, the violet one. We go into the subretinal space and we make a controlled drainage of the subretinal fluid. So this is very much a controlled drainage, and you can appreciate the cholesterol crystals and the shaggy necrotic tissue that lies under the retina. We maintain the perfusion of the eye through the anterior chamber maintainer that we keep infusing through the zonular fibers the fluid into the eye or stopping it. We can change the direction of the subretinal fluid drainage. And you see the thick, few centimeters of the subretinal fluid that is really full of cholesterol and shaggy necrotic material. By this time, the surgery, the retina has flattened out. There is no more retinal detachment. And we inject triamcinolone or any anti-VEGF at the time and leave the minimal remaining subretinal fluid to absorb over the next 2 to 3 weeks. Then do the peripheral laser ablation. And this is the intraoperative picture. Immediately after draining, you can appreciate the optic nerve, the triamcinolone, and the remainder minimal subretinal fluid cuff and the on the back. So If we do treat the ischemia and the early on, we can save eye and vision. Triamcinolone of 4 milligram resolved telangiectasia. However, late cataract develops, so we advise for lower doses, and we identify that coats can be accompanied by coronary vascular membrane. The second big is the persistent fetal vasculature, formerly called persistent hypoplastic primary vitreous. It's a congenital unilateral condition recognized at birth, and it has a whole spectrum of presentation. It's usually isolated finding. This is why it comes unilaterally, and it might be related to a genetic predisposition. The endostatin in the vitreous are lacking, and this is if you can appreciate the persistent hyaloid vessel as a very simple form that is not significantly associated with any visual or pathological symptoms into the eye. We can have a Mittendorf spot, we can have a persistent hyaloid vessel, we can have the posterior polar, the Bergmeister patella, or the extreme posterior form of posterior PHPV, persistent fetal vasculature with folding of the macula and the retina.
So what was on the left side of the image?
This is the cataract, and if you go deep, you find a combined form of disease. So this is the posterior subcapsular cataract. This is a red cam picture, so you can go up and down as you wish. Similarly, if you have we can find in this young lady coming with blurred vision in her right eye, but with a recent pneumonia that resolved this mass. And to reach a diagnosis in ophthalmology, it's very simple. You have to make first your anatomical leveling. So are we dealing with the vitreous? Are we dealing with retina? Are we dealing with choroid? If it's conjunctiva, are we dealing with epithelium or stroma and so forth? If you always think anatomically and then start to think about pathology, you will reach a diagnosis. You know exactly or approximately where you are. So the mass here is intraretinal. Why? Because there is a dipping vessel, draining vein, and the feeding arteriole dipping into the mass. There is subretinal fluid around it, and maybe some inflammatory components. So we have a retinal mass that is probably inflammatory in nature. So the anterior segment was okay. There were 1 plus vitreous cells, and fluorescein angiography shows a hypofluorescent mass with a perfusing arteriole and the draining vein with surrounding subretinal fluid with dipooling at late stage of the fluorescein angiography. The chest X-ray showed pulmonary infiltration, eosinophilia. Aqueous humor sample showed came positive for toxocara antibodies. So this was a case of a toxocara granuloma, and the origin of the toxocara canis is the visceral larva migrans coming from infection of puppies at home, presenting with general constitutional symptoms with the whole spectrum of disease. If we catch the disease in the acute stage, we have KPs, we can have up to nematodal endophthalmitis, inflammatory retinal disease that will end up by fibrous tissue. An isolated retinal fold is a presentation, the falciform ligament is a presentation of a myriad of inflammatory conditions affecting the back of the eye. So the margin here were discrete, the vessels were not dilated. It has a little bit of an umbilication with the retinochoroidal anastomosis. No calcification, and the ELISA tests were positive. She was treated with medical treatment, and the granuloma resolved. So what if you are in doubt? What if we see a similar condition? This is a similar condition with feeder vessels here, and we don't know what's going on. This is retinal mass. This is very similar to the previous mass. Just wait a couple of weeks. Tumor will grow, and this is an absolute definite sign of malignancy. The congenital toxoplasmosis differ from the other toxoplasmosis we see. So a patient coming with esotropia can have a retinoblastoma mass or can have a scar of a congenital toxoplasmosis. The scar can also be seated in the very far periphery with excellent central vision. So toxoplasma comes from Toxoplasma gondii. It's a congenital infection showing intracranial calcification, hydrocephalus, epilepsy, some mental retardation later on. And the acquired infection is a different entity from the congenital infection. So this is a patient presenting with right and left fibromuscular fractional retinal detachment in both eyes and a relatively small eye. We had no clue about the diagnosis at the time. She presented at few months of age. So a decision was to do a lensectomy, vitrectomy. The pupil was not dilatable. So we do a minimal pupiloplasty with the lensectomy. And we go for the membrane that is inducing fractional retinal detachment. So it looks like an ROP, retinopathy of prematurity. So the condition can be manageable as if it is a fractional detachment that differs a little bit from the retinopathy of prematurity stage 4 and 5. So in fractional detachment, we're very careful not to induce a retinal break. And we try always to remove the fibrous tissue from the underlying retina carefully and slowly. And we can identify the retina with the retinal folds in here. And we transit between posterior vitrectomy and anterior vitrectomy with indentation to deal with the fibrous tissue. The infusion is placed into the anterior chamber, and there is no place to be placed anywhere else in the pars pliccata in those kids. Liberating further and further the membrane and releasing more and more retina in very tiny eye and very small eye, and we are placed at 1.5 millimeter from the limbus. Of course, we need further contrast to identify the retina from the fibrous tissue. The treatment blue, the regular we use with the capsule staining, is the preferred method in this to manage and identify the membrane that stains well with the treatment blue. Going back into the vitreous, we can see this retinochoroidal scar, and we try with sharp dissection to isolate and remove the scar here. So this is the optic disc, and this is a scar going into the retinochoroidal junction. We go very gently, isolating the scar. Sharp dissection here is useful. We use a 1023 gauge needle. And after meticulous dissection, we could isolate the scar, the chorioretinal junction, as you will see in a minute here. These are very, very firm adhesion into the retina. So the moment this fold was detached, I could recognize toxoplasmosis. You see, this is a scar of toxoplasmosis where the retina is firmly adherent into it. So this is the moment where you feel like Sir Isaac Newton when the apple fell from the tree. You know, I found it. This is the patient. This patient had congenital toxoplasmosis. And we further liberate the retina and remove the scar. And actually, what happened is going back by and asking for a CT of the brain, you can see the severely affected CNS from hydrocephalic changes, and you can appreciate also the intracranial calcification that was associated with toxoplasmosis. This is a congenital form of toxoplasmosis. This is how the right eye looked initially. And after successfully resolving the detachment, you can appreciate the toxoscar and the flat posterior pole, and also for the left eye. Patient was put on anti-toxoplasma regimen for over a year, and can you play the video on the right hand side? And eventually she could fix and follow as she's growing up into the light. And you can see the very tiny eyes that really had hard time operating upon with the hyperopic correction. So we could restore vision in a very sick and ill patient. We have to remember those golden rules. If there is no such a thing that an unexplained retinal detachment in a child. So this is really important. If a child comes with his mom and the child is kind of a naughty child that moves everywhere and he plays a lot at school and he doesn't listen to anyone, and the mom would presume that he had a trauma. So the trauma to the eye, the blunt trauma that would induce retinal detachment, will leave some evidence of trauma. We leave some lid edema, some conjunctival chemosis, some subconjunctival hemorrhage. So never believe a mom coming saying, yeah, he probably fell down on his eye or anything bad happened to him. So detachment is retinoblastoma until proved otherwise. Never miss a mass, and if this is presented with hemorrhage, look to the upper eye, examine the fellow eye, you'll probably find some tumors. Unexplained uveitis and anterior chamber vitreous seeds, as was previously mentioned, are a sign of retinoblastoma. You see, this is not this is not an inflammation because the eye is so quiet. This is an anterior chamber retinoblastoma. This child was operated multiple times because of the misdiagnosis of retinal detachment. Golden rule number 2 is an unexplained uveitis presented with anterior chamber seeds in a quiet eye. This is retinoblastoma until proved otherwise. A diffuse infiltrating retinoblastoma. This child was not diagnosed as retinoblastoma because he was an 11-year-old and he was a robust guy coming to the clinic. So the doctors never thought about retinoblastoma coming at this age, and he was operated multiple times, and it ended up by major catastrophe. Again, a hypopyon in a quiet eye indicates a retinoblastoma. Do an ultrasound if you cannot see. The diffuse infiltration shows sometimes calcification, though it is misleading because there is no real mass into the eye. Again, a hypopyon with 6/6 vision. We have conservative management for those patients these days, but I mean, the rule is do enucleation if you don't resort to the complicated management of treatment of intracameral chemotherapy injection. So again, uveitis, strabismus. This is a mass that came with strabismus. Hyphema, spontaneous hyphema or vitreous hemorrhage or retinal detachment, and unilateral ophthalmos. There is no such a case meaning unilateral ophthalmos. A secondary glaucoma unilaterally in a child is retinoblastoma until proven otherwise. And if you can appreciate the vitreous seeds here, do an enucleation and have a very quiet mind about it. If you do enucleation, do minimal enucleation. Never pass a needle through the globe, because if you open the globe, this child will be dead in 6 months' time. Get as long of an optic nerve stump as you can. Reserve this for the advanced stage, and avoid preserving the eye in necrotic tissues, and always give hope to the patient. Thank you very much. We'll proceed and finish for 1 hour, guys. So go to presentation number 2. Okay, so how many of you saw Coats disease? Okay, fine. Yeah, the stages were advanced. That's advanced.
Yes, advanced.
Advanced stage. So what do you do for that?
I am a pediatric ophthalmologist, so we refer the patient to vitreoretinal surgeon.
Okay.
They give.
That's small.
In practice, we usually give suprachoroidal kenacort nowadays.
Suprachoroidal kenacort. Why? I mean,
So it really works to absorb the exudation water, and also the few exudates becomes less marked and the retina becomes a little flat. But the results are not
Yeah, I think you saw the very thick viscid subretinal fluid, and I don't think there is a way for the RPE to absorb this. It's very difficult. I think at one time it had to be drained. Anyway, in practice we encounter unusual cases. So this is a 3-month-old female coming full term with normal vaginal delivery. She's very healthy. Mom and dad are doctors. And over the last 3 months, she bled 3 times, like once a month for the last 3 months. And then she was giving steroids and cycloplegic, and the things resolved. Patient come with this mass into the anterior chamber that you can see on UBM. And not only the mass here, there were seeds everywhere. And these were the seeds, this is the mass, and these were the seeds onto the capsule, the anterior capsule, and the iris. The other eye is quite normal, the fundus also is normal. So, how many of you have seen on the anterior chamber retinoblastoma? So does it make sense even, to have, we don't have photoreceptors on the iris, right? So retinoblastoma come from photoreceptors. We don't have photoreceptors even as an anomaly. So if you look really good, it looks like the seeds of retinoblastoma on the very far periphery, and this is the list of differential diagnosis. This retinoblastoma that's seeded into the anterior chamber, medullary-epithelioma of the ciliary body that also seeded into the anterior chamber, are these leukemia, strictly unilateral, the child is totally healthy. Is it traumatic or some blood disorder? And the systemic status is really healthy for this patient. Looking at her skin, there are depigmented patches that really showed up nicely on blue light. You see there are patches of depigmentation. If we decrease the light a bit, you will see the patches of depigmentation. So the definition of juvenile xanthogranuloma is immediately made at this stage, and we prefer to do cryo to the presumed mass into the anterior chamber. A simple freeze technique with a depth of maybe 1.5 to 2 millimeter. We can see and appreciate the ice ball going to the iris root in here.
Excuse me, sir. Are you really applying on the limbus and the corneal area?
Yeah, we apply cryo on the cornea.
Right. So, does it not hurt or the epithelial damage or the anterior stromal damage?
No.
No? Okay.
This is non-epithelial damaging cryo. No, we just apply cryo on the mass there, and we do this a lot, by the way, in tumors and ocular surface neoplasia. The cryo affects the highly dividing cells. So even if you have an ulcer there, that will ensure not, it will resolve. It's a common practice to do that. Immediately post-operative, you can see shrinkage of the exudation that was there. Maybe a month after that, you can see disappearance of the seeds, inflammatory seeds. So the juvenile xanthogranuloma is a benign proliferation of dendritic histiocytes, which is divided into a non-Langerhans cell histiocytosis and a Langerhans cell histiocytosis. This is the recent classification. It affects infants below 2 years with the main cutaneous development, cutaneous involvement of macules or discrete firm papules on the skin. Patient now is like 3 years old and she didn't get any of the papules on the skin. Ocular symptoms are important, affecting the iris in 70% of cases, and there is a high incidence of myelomonocytic leukemia in association with neurofibromatosis type 1. The iris lesions are described in the literature to be unilateral, localized, yellowish, vascular, elevated masses, with diffuse thin infiltration and maybe heterochromia and spontaneous hypema. This is what this patient had initially, and I don't think it has been described at that level because of the very early and premature age of the child. Management is typically with topical steroids that you taper over a few months, periocular steroids, systemic steroids, low-dose radiotherapy, multimodal chemotherapy, and cryotherapy applied to the residual mass. So the Langerhans cell histiocytosis is a clonal disease. It's an immune reaction of the monocyte macrophage system with proliferation of CD1A plus CD207 positive immature dendritic cells due to continuous immune stimulation. So the body is attacking itself. It can have it can come in single site or multi-site, and it can have an organ involvement or no organ involvement. The most recognized form of Langerhans histiocytosis is the orbit involvement with bony destruction. And this orbit involvement with simple scrapping of the tumor, the bone will reconstruct and everything will settle down and go away. Stains for CD1A and CD207 were positive for, in this case, with orbital involvement. So you remember that retinoblastoma can present as anterior chamber seal, but it has an origin in the retina with a mass in the retina that we can identify by indirect ophthalmoscopy, ultrasonography, or RETCAM photography. And in those cases, enucleation is the solution. In here, the skin examination of the child, the skin examination clinched the diagnosis and made the recurrence of hyphema a lot less frequent than usual. So this patient had a unilateral ophthalmos. There is no such a thing as unilateral ophthalmos. Ophthalmos is a bilateral disease, and he was operated from glaucoma. And you can see the eye full of retinoblastoma and the extraocular extension equaling the size of the eye. So at this stage, if you call for enucleation, many patients will refuse to do this. But I mean, if somebody would propose surgery, they will rush into surgery, hoping to save the eye and vision, and you end up by major catastrophe with lymph node involvement, systemic dissemination, CNS involvement, and death. Another case with pseudo-orbital inflammatory signs. Patients were reluctant to treat the eye, hyphema, as you can see, and tumor growing into the orbit. You see, tumor has grown through the emissary veins into the extra scleral space involving the orbit. So this is another case that is really unusual, but it makes us think about how to manage the case. You know, we have to think about the anatomical localization and then the pathological entity, and we have sometimes to link this to systemic status of the patient itself. I don't know if you see melanomas in here. Are there any melanomas in Pakistan? You see, every now and then, right? No? Yes, ciliary body, uveal, iris.
Not so much. Probably heard of one, but not.
Very rare. But I mean, I think the rarity comes from it's rare, and we do enucleation, right? We don't have conservative. But I know in Singapore that they see melanomas, you know, and they're not so far away. And then we thought the same 23 years ago in Egypt that melanoma are rare and we don't much care about. If you offer the conservative management, you will see more and more of those cases coming to you for the conservative management.
So I have seen
You have seen.
cases in 1 year in
Excellent.
Afghanistan.
And you work in a big city, in a small city, sir?
Yeah, big city.
A big city.
Surrounding.
And you do vitreoretinal? What do you do?
No.
General.
Inoculation. We did PET scan.
Yeah, I understand. Are you a general ophthalmologist or
No.
general ophthalmologist? So there is melanoma. We really have to identify and think about management. So melanoma are classified into small, medium, and large, depending on the largest tumor dimension and the thickness. So less than 10 millimeter or 3 millimeter in diameter and 3 millimeter in thickness. So this is small to the larger melanoma. As it is small, it comes as dome shape, and then it goes into mushroom shape, and it may fill the globe sometimes. The larger the tumor, the more the tendency to have extracellular extension. And we have also the difficult diffuse infiltrating type, difficult to diagnose and manage. For small tumors, we observe, we use brachytherapy, which is a local form of radiotherapy, and maybe adjuvant thermotherapy. For medium-sized tumor, we use brachytherapy, thermotherapy, and resection, plus brachytherapy. For large-sized tumor, we use enucleation. We do resection and brachytherapy, or sometimes we resort to endo resection. So what is brachytherapy? Brachytherapy is a focal method of radiation delivery to the intraocular tissue. and we use the radioactive isotopes. In Egypt in 2003, I elected to get the ruthenium plugs. Ruthenium plugs are beta form of irradiation that can stay for up to 2 years. We can use them for up to 2 years, which makes it a bit of cost efficient. For melanomas, we deliver an apical dose of 70 to 100 gray to 100 gray, 10,000 centigrade. And this gives a very localized, focused radiation dose to the tumor with minimal tissue affection on the site. So these are the forms of isotope. Ruthenium is used in Egypt and Europe. Iodine 125 is used mostly in the United States. And these are used as primary treatment modality to deliver radiation dose to the tumor, covering the whole tumor borders, or secondary treatment modality after in conjunction with other modalities of treatment. This is the first case treated in Egypt in March of 2003. Tumor here was due for enucleation really, but we were starting the service and we had the plaques and they were hot. You can see the tumor around the optic nerve. There is a natural resistance to infiltrate the optic nerve. So, and the tumor was not that thick, so we used a radioactive notched plaque. And you can see this is the tumor, the plaque put into position, and you can see that the vascularity has totally gone and the tumor has totally regressed over 15 years of follow-up. We were successful in managing the difficult condition that might have necessitated enucleation with a plaque application at the time, and the tumor has totally gone. We cannot appreciate the thickness of the tumor over follow-up period. This is another young lady, 54-year-old female, coming with distorted vision when the posterior located macular melanoma with orange pigment and subretinal fluid. The thickness was 4.6 within the reach of the ruthenium plaque, and we applied the plaque targeting 80 gray at tumor apex. The plaque was removed in a few days and was treated with thermotherapy as an adjunctive treatment, and you can appreciate the total hypoblocked fluorescence and hypoperfusion of the mass that resolved with time, and we could successfully preserve some of the central vision for this patient because of the tight application of the plaque on the posterior edge and the decrease in thickness of the plaque. This is the effect of the plaque, the radioactive plaque. It induced like effacement of the vascularity, and you can see that it was very useful to arrest the growth of the tumor and kill the tumor cells with, at the same time, a partially healthy macula and a healthy optic nerve. Melanoma do not respond to external beam radiotherapy, so there is no management profile or management way to do this with photon therapy. There's no at all management for that. So we offer a lot of treatment for those medium to small uveal melanoma. So what about the large ones? The large ones, it's either enucleation or we do the resection technique. The resection technique is formed by fashioning a flap over the tumor with a safety margin. The flap, we dissect the 90% of the thickness of the flap, and we go to remove the melanoma in total. We don't leave any single cells of the melanoma. You see here, this is the retina, and this is the melanoma coming with the pseudocapsule, and this is how the posterior pole looks after the surgery. So this is a case of a 60-year-old male coming with superior choroidal melanoma. You see the MRI looks good, and while making the scleral flap, we notice an extra scleral extension. And this was quite a surprise that was not detected. You see, this is the flap in position, and this is an extra scleral extension. So the thinking was to do a partial thickness flap and come at the site of extra scleral extension and make a hole in the flap to allow to keep the extraocular extension related to the primary tumor. And as you can see, we successfully could preserve it within. Now we go to the deep sclera. We isolate the deep sclera at 360. We use here the laser to, after isolating the sclera, to retrieve the melanoma on one side, and then the choroid, we kind of burn and cut through the choroid, normal choroid, while taking the tumor out. This is a healthy choroid. It's not bleeding because the patient is under severe hypertensive anesthesia, and we use the laser here to augment the hemostasis. Tumor is here, the retina is here, and tumor is gently coming out of the eye. You see, this is a big tumor coming out of the eye with the retina in position. We could preserve the retina without any breaks and with minimal bleeding, as you notice.
So which laser you apply?
But any thermal laser, so if you have an argon, I use the diode. Green is good as well. So we put back the flap in position, but we have a hole in the flap, right? So we use part of the remnant of a scleral button to cover the hole in the flap. And this was quite sufficient to reform the globe and leave the globe intact as much as possible. We depend on these stages on the anesthesia, and you can see tumor is totally excised with the extrascleral extension, and we have even a safety margin of normal choroid around the tumor. So this was the post-operative follow-up of the patient, and we could restore and have a decent vision in this patient as well with those techniques. We used here because of the weakness of the scleral transpupillary return mortality to augment and enhance our treatment. It's a beta irradiation, thickness goes up to 6 millimeter, and there are simulation plans that we know exactly when we put the plug at a certain time, when to remove it and to deliver a minimal dose. These are examples of post-operative. You notice here that the tumor is quite posterior, but it's not touching the optic nerve. So if it's 3 millimeter away from the optic nerve, even on the nasal side that is cumbersome, we can successfully remove. This is second day post-operative of the patient, preserving the central vision. And this is maybe 10 to 15 years later, patient is doing well and keeping her vision. She had some astigmatism and she's wearing her glasses and happy with the results. Another tumor here, the ultrasound is important to detect that the tumor is not touching the optic nerve, it's away from the optic nerve. We had to go back for a second vitrectomy in a 3 months' time to remove the blood and restore the anatomical position of the retina. A very nice scar. A plaque will be very on the sclera, aiming at 3 millimeter thickness would definitely improve our results on tumor control and recurrence, which exceed 95% in those cases. So here are the limitation of the plaque, more than 4 clock hours, 22 millimeter diameter, because the biggest plaque is about 25 or 26 millimeter. Touching the optic nerve is the limit, and now we question the extraocular extension as a contraindication of the tumor. So we have to think about an en-bloc tumor excision, which can be achieved in those tumors, and we achieved in a paper we published years back 75% success rate. So this is my third presentation. I think we should move to the fourth presentation. We have this book as PDF, and it shows up all tumors from the eyelid to the ocular surface. So whoever is interested, we can send it to you gladly. Yeah. If you have an extensive eyelid mass or an epipalpal mass, so of course it's normal to think malignancy. This is quite normal to think that this is like, you always remember that if you have an elderly patient coming with what seems to be a chalazion, you have to think twice, because with age, all body secretions go down. So a chalazion is not the way to think. We have to think about malignancy. So the gentleman came with excision of a chalazion, and then a second time excision of a chalazion, and then at the third time of recurrence, he was referred for further management. A simple biopsy showed sebaceous gland carcinoma. And the decision was to do a total, almost total upper eyelid excision with a transposition flap, bridge flap from the lower lid. That was left in position for 3 weeks. The mass is huge, mainly the whole upper lid, with a decent cosmetic post-operative results. So now comes another patient, 64. he had previously excision of upper lid tarsal mass, and it was a conjunctival palpebral malignancy. And beneath this puffiness of the upper lid, if we rotate the lid, you can find a huge mushroom-shaped mass, some pigmentation here on the lid margin, and also on the caruncle. The caruncle had also some pigmentation. So we are dealing not only with a localized mass that we can do a resection on, but with a more diffuse mass that proved to be a melanoma with affection of the lid margin here and the caruncle on the other side. So the decision here was to do a tumorectomy, just remove the tumor, cryo the base and the pigmentation here and the pigmentation at the caruncle, and we put an upside down plaque. We put the plaque in upside down position to deliver 100 ray to the tumor base, and this pigmentation over here, in case it is a malignancy. And you can see we have an extremely good result with a little bit of symblepharon here, but the tear film is quite preserved, and the base of the tumor has totally gone over years of follow-up. You can see the tear film is good, no malignancy whatsoever, with a decent result in this patient. So this was another female presenting at age of 75, and she was beyond this huge melanoma came from PAM, and there was no way for her to do an exenteration or to accept this or even to go into the OR. So it proved to be a melanoma, and you can see the primary acquired melanosis giving rise to this huge melanoma. The safe tumorectomy, tumor base was here, we did cryo on tumor base, and we put a plaque in upside down positions, and the post-operative was really nice as a way of relieving her, and with the PAM, the primary acquired melanosis that is probably with dysplasia was cryoed, and the patient was put on follow-up. So the brachytherapy, we have two types of radiation, alpha particle and beta particle and gamma rays. Alpha particles are present in the routine external beam radiotherapy, the photon therapy, and they are not effective in melanoma at all. Beta particles are negatively charged, and gamma rays, they have no electrons, similar to X-rays, but they come from a nuclear reactor. With the unit we use is the gray, which is the System International Unit for absorbed dose, which is 1 joule per kilogram. This is the unit of radiation we use in our practice. Radiation goal is to arrest cell mitosis by interfering with DNA synthesis and destroy the reproductive ability of the tumor, and it does induce vascular occlusion. So brachy here, nearby. So we put a plaque near the tumor, not in a teletherapy that the radiation comes from the very far periphery. This is a more elaborate list of the plaques we're using, and we use the Egypt ruthenium 106. If you have an extensive mass like this, for this patient that was not really, that was really reluctant to surgery, and he was proved to be a recurrent squamous cell carcinoma. This is a bad seeing eye, and the tumor is everywhere. You can see the tumor in the right eye and in the left eye, infiltrating the orbit, infiltrating the skull, and everywhere into the orbit. You have to remember that the radiation oncologist is quite helpful in giving stereotactic radiotherapy. And you see, this eye that was really covered ended up by being the better seeing eye after doing cataract surgery. So here, we're offering quality of life to the patient. The patient was almost blind. This eye was really bad in vision. The tumor has totally regressed over time. We know that it might recur, but at least he will spend a year and a half having quality of life and could be ambulating around. And this is how we started, and this is how we ended. This was an ugly ulcer, an ugly malignant ulcer that there was no way for it to be cured. And now patient has survived with a huge regression in the tumor masses in both organs. Another gentleman, elderly, coming with recurrent melanoma in the conjunctiva and the eyelid. Tumor was extended into the orbit on an MRI scan, as you can see. And the decision here was to inject bleomycin. Bleomycin is a very cheap antibiotic that we use less frequently as antibiotic, but it's used as sclerosing agent and is being used increasingly in melanomas. We inject into the mass directly intralesional, and you can appreciate regression of the component, as we can see regression of the tumor mass as well over time. You see, the tumor mass that was extending here has almost disappeared over time. And this is how we started, how we ended at 18 months of age. The PET-CT showed affection of the systemic status of the patient. Patient was metastasizing elsewhere. Hence there is no need to do an excenteration because the tumor has already gone away. And we use the bleomycin in other entities and other tumors in a dose of 15 international units of bleomycin for 6 weekly doses. We give a dose every month and a half for 3 successive doses, and we look at the response of the tumor. In sunny areas like here, we can encounter diffuse conjunctival intraepithelial neoplasia that is coming over the surface of the tumor, and it is really diffuse. It's not a localized or a focal mass that we can go surgically and excise. It's a diffuse mass like that. So here, the options are very limited. What can you do about the cornea with breaching of Brooks membrane and maybe the stroma? So, and the tumor is really extending around the limbus in such a way. The mitomycin here, think about it, because it's really, really efficient in a dose of 0.4 milligram per milliliter, prepared as drops, and we give over cycle therapy 1 or 2 weeks of treatment, followed by 1 or 2 weeks off. Many cycles have been described in the literature. Think about plugging the punctum, giving some steroid and duplicate drops, and maybe combining with interferon 2 alpha. After 3 cycles, you can see the magnificent regression of the tumor from the cornea, and the patient had only residual fibrous tissue over the conjunctiva. We were a bit scared about the nature. We excited that it was fibrous tissue with no malignancy at all. So it's good to preserve vision, right? From very drastic and nuisance condition like that. So we encountered this lady coming from Yemen. She's a 74-year-old female coming with an epivalvular mass for 1.5 years with poor vision and mature cataract in this eye. We decided to manage it conservatively. It's very useful to use the tools of photography we are having. So this is how the mass looked like. Almost 270 degrees of the cornea, and the conjunctiva is involved with this huge pigmented mass. You see the angry vascularized vessels that go onto the tumor. Notice that there is on UPM a plane of cleavage, or a presumed plane of cleavage between the mass and the cornea. And this is the limbal part of the extensive epivalvular mass. So for such lesions, enucleation would be a solution, but having seen the investigation and looking into the investigations ourselves, we decided to try conservative treatment. We will take 3 to 4 millimeter of safety margin, cauterize the vessels, inject xylocaine adrenaline, and with a blunt spatula, we could go under the tumor that was really not invading the epithelium. And this was something really, to our surprise, went so smooth, without even having any resistance in pushing the iris spatula. So now we're quite sure that it is not infiltrating the cornea, it's sitting on top of the epithelium, to our luck and to the lady's luck as well. If you treat tumor or think this is a tumor, always handle the tumor through healthy tissue. Never go and hold the tumor with a forceps or anything like that. And always ask the nurse not to give BSS on the cornea, because the jet will take some cells into the inferior fornix that will be a main cause of recurrence. And the tumor has come reasonably easy with blunt and sharp dissection. We do not cut through the tumor, we just do a total excision of the tumor using scissor, blunt, and sharp dissection as necessary. We keep the field clean, and you see the epithelium, to the surprise, is quite intact. and the tumor was totally excised. So if you remove stem cells from the limbus at 270 degrees, we would expect definitely dry eye, right? What shall we do about the coming dry eye that the patient suffer from? Now that we are sure that the tumor is taken out, as we go through the surgery, we think about the general condition of the eye, not only the tumor that we successfully removed from the eye. Once you take the tumor out, exchange your instrument, change your gloves, and work with a whole new set of instruments. Do the cryo in a double freeze thaw technique over the conjunctiva and over even the limbus to kill any residual cells that were possibly left over. You see the intact epithelium, it's really shining and smiling to us, back to us. So just a little bit of scrapping, nothing significant. Do not go deep into the sclera and do not go deep into the cornea. So we took a limpid autograft from the other side, from the stem cells. We decided to put it on top here and cover the whole thing with an amniotic membrane to preserve the function of this eye, because we knew that we had a radical management of the tumor, and we were successful in preventing a further massive surgery. So this is the limpid stem cell autograft, like the one we do in the region. We suture it to the limbus. We cover the whole thing by amniotic membrane.
Venules or the arterioles or both of them. So each one of them sometimes is its own. Let's have a quick look on the retinal vessels. As you can see here, you have the veins, you have the arterioles, you have the optic nerve head, and this is the normal retina. So we consider retinal vasculitis as part of the spectrum of posterior uveitis. You might sometimes find only vasculitis without any other signs, and this is considered part of uveitis. So it's a frequent, the problem with retinal vasculitis, it is mostly a manifestation of systemic disease. So this is how the retina or the vessels can look in inflammation. Compare that to the vascular disorders in diabetic retinopathy. For example, the big difference in the retinal configuration and the vascular configuration. We divide retinal vasculitis into two main clinical entities, depending on the etiology, infectious and autoimmune, like most of the uveitis entities, and the clinical features, how to diagnose retinal vasculitis. Number one is the sheathing of the blood vessels. This sheathing is nothing but inflammatory cells surrounding the vessels, whether the veins or the arterioles, as you see here in this patient here, and vitreous cells, quite often retinal infarcts because of the occlusive vasculitis which is taking place, and of course due to the ischemia, the retinal hemorrhages. Let's go one by one. So tuberculous vasculitis. Well, you know it's caused by this mycobacterium tuberculosis and the pulmonary or extrapulmonary. Quite often we see a patient with no signs of tuberculosis, but he presents with vasculitis quite often, even sometimes with cystoid macular edema. It's asymptomatic in 90% of the cases, and the first presentation is usually vasculitis, and usually sometimes you get a granulomatous uveitis. How to diagnose? You probably know more than I do how to diagnose the tuberculosis by different tests. So what do we find in patients with tuberculosis? A tuberculous granuloma is a presentation, and a very significant retinal periphlebitis. Take this patient here. This was a 16-year-old girl. She presented with as you can see, a PVR form or an aggressive form of proliferation and lost eye, the upper there. But this eye was 6/6 vision, and we did her the fluorescein, as you can see, the very significant periphlebitis. She was not previously diagnosed as tuberculosis. We investigated her, and she had a cold abscess here. She had the treatment, and she actually got much better. And this is the typical vasculitis you find in tuberculosis. Eel disease, I'm sure you find that quite often here in this part of the world. In our part of the world, we see that quite often. So this is an absolutely normal patient, usually male, and they present with an occlusive form of vasculitis, mainly periphlebitis with peripheral neovascularization, sometimes with an aggressive form of fibrosis and fractional retinal detachment, a lot of vitreous hemorrhage as well. It has been associated with TB. Yes, it has been identified by PCR, some of the DNA fragments in some of those patients. Some of them just present with a central vein occlusion or a branch retinal vein occlusion. Rift Valley fever. Have you seen Rift Valley fever? Anybody? Well, you will see it because it's spreading. It's spreading. So, what is Rift Valley fever? This is an arthropod-borne fleabovirus, and the presentation is usually by severe headache because it's a neural infection. If they survive, they are going to present with this, visual disturbances. Why is that? Because they develop retinal vasculitis and retinitis. So, post 2 weeks after they get this headache or this encephalitis, they present with loss of vision, have extensive retinitis, usually the posterior pole with occlusive vasculitis. These are typical cases which we've seen in an outbreak in Egypt a few years ago. This typical retinitis and what I call amputation of the retinal arterioles due to arthritis. So dengue fever, again, one of the viral infections. They are mosquito-borne, like the Rift Valley, by the acute fever, malaise, rash, and it's like a flu, and they develop some sort of ocular manifestation, self-limiting. Mind you, both of them, they have no treatment. There's no treatment for those. So this is the typical dengue fever, conjunctival hemorrhages, quite significant, and they get these macular occlusive vasculitis in the macular area in both eyes, and with severe macular affection. Cytomegalovirus, you probably also know that it's a herpes family, and usually they are immunocompromised with this tomato sauce and extensive vasculitis with retinitis in patients with HIV. We see that quite often, and you actually saw cytomegalovirus a lot during the corona or the COVID era because of the extensive steroid treatment in some of the patients. Unfortunately, they got cytomegalovirus, and of course in bone marrow transplantation. So essentially, it's a necrotizing retinitis with severe extensive vasculitis and in retinal infarcts. A frosted branch arthritis. Have anybody encountered frosted branch arthritis? Well, these are absolutely healthy patients, and they develop this extensive form of vasculitis, bilateral in most of the cases, with all the findings of the vasculitis, sheathing and severe hemorrhages, infarcts, and so on. And the only thing is that they have an ESR. It has been incriminated that the cytomegalovirus is actually the cause, and this is some of the patients here, extensive hemorrhages, and they end up with severe ischemia of new vascularization. Acute retinal necrosis. Who encountered acute retinal necrosis? It's there, it happens, and these are again healthy patients. Most of the time, sometimes you find that with immune-compromised patients. It is an infection with the herpes family, mostly herpes simplex, or sometimes with zoster, occasionally with the Epstein-Barr. So there's an acute loss of vision, occlusive retinitis, occlusive arthritis, with extensive retinitis, like the picture you see here, peripherally, essentially, and you have the immunocompromised patients with a very mild vitreous reaction and what we call the port. You probably know that, and it is widespread necrosis, and these patients develop retinal detachment because of the typical picture here, as you can see here. So this is again a viral infection, acute necrosis, herpes simplex, zoster, prompt antiviral. The only way to save the eye of these patients is to really be very aggressive. So again, the systemic antivirals, the intravitreal antivirals, and sometimes you need to do a vitrectomy to save the eye. So this is one of the patients who is, this is typical. I don't know if you've seen that. It was, I showed that earlier in the morning. So this is typical with a severe vitritis. All right, toxoplasma, you probably know that the causative is the protozoa, toxoplasma of the eye, intermediate host. We are the intermediate host. How do these patients present? Usually, this is the picture. You have an old granuloma, and then you have a new active lesion on top of that, and they have a granulomatous, very mild antechamber reaction. But the significant thing, which is diagnostic, is the area of retinitis and the vitreous reaction on top of that, with vasculitis as well. With sometimes in HIV patients, they have this miliary form of toxoplasmosis. And this is the typical picture you see, a hot disc and the vasculitis in these active patients. Syphilis, yes, treponema pallidum, and they present with acute neuroretinitis, and rarely they develop the vasculitis. However, now we go to our non-infectious types, which is Behçets. I don't know if you see a lot of Behçets. We see a lot of Behçets patients, and this is the main cause of uveitis, blindness in our part of the world. So it is mainly uveitis. However, don't underestimate the presence of vasculitis. So you have this hypopion, but if you look at the back, you have the typical vasculitis, the exclusive form of vasculitis, and optic neuropathy with extensive vitritis sometimes. And as you know, it is the pan-uveitis. Mind you, they have systemic complications, whether neuro-Behçets or sometimes GIT, mesenteric artery occlusion. So again, if you have a patient with vein occlusion or a young patient, always suspect Behçets. And this is again, I believe that these patients also have some sort of a choroidopathy and a choroidal circulation problem. This is the end of the story. These patients end up with optic atrophy, almost the total atrophy of the macula and the retina. Okay, so sarcoid, you know about the sarcoidosis. Again, one very important cause of vasculitis. Essentially, it is a periphlebitis like tuberculosis. It is the twin of tuberculosis without caseation. So these patients have venous occlusions, peripheral vascularization, new vessel formation, vitreous hemorrhage, and sometimes they present. And this is the typical vasculitis you see in the sarcoid patients. Again, vascular occlusions, mainly the venular occlusion. Systemic lupus erythematosus. It's a multi-system disease, as you know, one of the connective tissue disorders. Lymphocyte B, lymphocyte hyperactivity. And the diagnostic is you have the raised antiphospholipid, the double-stranded DNA. So this is again the typical presentation of a patient with systemic lupus. The infarcts everywhere and the vasculitis. And if you examine the patient, you probably have some sort of nephropathy, and you really have to have this in mind. So lupus, retinopathy, retinal infarcts, retinal arterial occlusions, optic neuropathy, quite common, and peripheral neovascularization sometimes. Polyarthritis nodosa, again one of the vasculitis, which has a different presentation in the eye. It's, as you know, a necrotizing inflammation of the small and the medium arteries, and they have systemic findings, whether weight loss, and it is quite often after a B form of hepatic C, B, hepatitis B. Yeah, hepatitis B. Often they develop the polyarthritis nodosa, and they have retinal infarcts, retinal arterial occlusions, and hypertensive retinopathy with an important choroidal vasculopathy is a significant finding in these patients. Non-Hodgkin's lymphoma, yes, can develop again. This is one of my patients who has non-Hodgkin lymphoma, and he presented with this type of vasculitis as well. Okay, and important, this is almost the last slide. I just want to direct your attention to this form of vasculitis, which has been actually described recently. This is the vancomycin-associated hemorrhagic occlusive retinal vasculitis, and this was reported after cataract surgery because of the use of vancomycin in the irrigating solution. They developed this form of hypersensitivity reaction. So how do they present? They present an uneventful surgery, and 24 hours or 48 hours, they start having loss of vision and delayed onset of sudden painless decreased vision, poor vision at presentation, and very mild reaction. And the cause was the use of intraocular vancomycin. So please do not use vancomycin in the irrigating solution as a routine. Why is that? Because they are going to develop this type of vasculitis. And this is no joke. I've had, not my cases because I stopped that, I've had referred cases with this form of horrible vasculitis, and they end up with new vascularization and neovascular glaucoma. So please do not use vancomycin as a routine. Only use monofloxacin if you like, and this is the type of occlusive vasculitis you meet in those patients. So what is the cause? It's a hypersensitivity reaction type 3 with immune complex deposition in the vessels. Due to the problem in those cases is that they develop, they used the vancomycin even in the other eye because they did not know. So alarm, be careful with the use of intraocular antibiotics. The differential diagnosis of this is endophthalmitis by retinitis and central retinal artery occlusion. Again, I end up with this invitation for you all to attend our meeting in Egypt in March, and thank you so much.
Thank you very much, Mohammed Sulaiman, for an excellent presentation on a very complex issue, because the little carelessness can lead to a permanent blindness in these cases. So if there is any question, he would love to answer that. Thank you very much, sir. You can join me here. And now I would like to invite our next speaker, Marius Saravia from Brazil, and he is going to deliver his talk on mystery cases in ophthalmology.
So,
And I would like to request all the speakers to adhere to the allocated time, which is 7 minutes for each speaker.
this is a case after this magnificent lecture about vasculitis. You are going to make the diagnosis very easy. Well, next, what is this one? This was a female of 62 years old. This case was more than 10 years ago. She came to us with visual acuity decreasing in her right eye, 3 months of evolution. She referred like a black dot in the front. In the other eye, in the left eye, she said that, well, maybe I'm feeling different. I don't see as I used to be. No remarkable general history. And as you can see, visual acuity was really count fingers, just 20 centimeters, so just seeking vision. But in the left eye, we checked this 2 days later, and it was the count of fingers at 1 meter. Whoa. At the by microscopy, it was one cross of cells in both eyes, and intraocular pressure was normal, and the fundus was like this in the right eye. So it was something really strange, all these whitish lesions spread. Some signs of, I don't know if you in this projector you can see in this image, you can see, because we can see better in the TVs than there, but some signs of vasculitis and something strange. The other eye was well, quite good, but if you can see, you can't see in the picture, but it is a little blurry. You agree with that? Okay, just to tell them because you don't see that's it. But actually, well, we were in front of a bilateral panuveitis with retinitis and some vasculitis. So, if you hear Mahmoud, you already know the diagnosis or not. I don't know.
So why is sarcoidosis not added in this case? Sarcoidosis should be there.
Oh, okay.
It's an old age.
I'm kidding. Maybe could be syphilis, could be cat scratch disease. Actually, it doesn't fit to any of this. But Wegener, remember how old is this case that we don't call it Wegener anymore. It's granulomatosis plus polyangeitis ANCA positive. Well, Beset, I'm not going to, but to tell you about Beset because we learned everything from you in this area of the world. Maybe Whitewood, but just because we were looking for something, but it wasn't clear. The ancillary tests where we made OCT, fluorescein angiography, and a battery of tests for looking for something, the hepatogram, creatinine, for cat scratch, we look for Bartonella, and just in case, toxoplasma. The X-ray was also just in case, but we didn't have anything clear about this patient. Well, we found this time domain OCT, and look at the angiography. Well, it was a very strong image for us with these areas of non-capillary dropout or silent vascular silence. All the vessels are compromised near the optic disc. Well, for us was very tricky. We didn't know how to do. We started look at there is something interesting. Maybe those who are familiar with this image probably are suspecting something. But at those time, because they are apart, I'm not going to tell it just to keep to not to spoil the case. But this image has some pattern that now is recognizable, but in those time it wasn't described yet. So, well, the evolution was we only found IgG positive for toxo. When in those parts of the world we really get used about toxo as you, but there we have a lot of toxo. And we didn't think really this was a typical toxo, but it was the only thing we had. So we put her a treatment of azithromycin and prednisolone, and the patient started to improve. Visual acuity was a little better. We said, well, it's atypical, but it's working. 3 weeks later, we have an improvement in the left eye, so we were quite happy. We start to down prednisone, and we called the patient for continuing the treatment with anti-angiogenics for the edema. The patient came like 2 or 3 weeks later, and in the next visit, she told us, my vision is worsening. Well, and now the vision was really worse. We assessed again, and in the left eye, that was her only eye, we found these lesions, these whitey lesions, It's a pity that really it's very different the image we have in the screen. But anyway, well, we see these white lesions, irregular, spread uh, along the retina, and we didn't know. Actually, we didn't know what to do with this patient. So we thought maybe we have TB. We also have a lot of TB, like you hear. Why not? Let's do some treatment. We'll see. The PCR was negative, and 5 days after treatment, we see that. Well, as you see, this is the retina was worsening. We didn't know what to do, so we decided to go for a piece of retina to get the biopsy. Just, I'm not going to ask you for the diagnosis, but raise your hand who has positively a diagnosis. Jay, Danny. Okay, Danny. Raise your hand.
The residents or?
No, what? All of you. Mahmoud?
If we have.
Yes, you know what is it.
Me too.
You too. Okay, you should. Well, actually, we took I went in, I took a piece of retina and I sent it to the pathologist. You see, uh, this was what we found during the surgery. You can see that whitish. Of course, we choose to take a piece from the right eye because it was worsening. She has at that moment she has no light perception, and the piece was this. Okay, now you got full of lymphocyte. We don't recognize any structure along the retina. There's no layers, no just lymphocytes. And if you see the tinge for CD40 are those brownish cells, and you can see that they're full of them. When you in these cases, if you found just a little bit of them, you can get the diagnosis. And so the diagnosis finally was, and you can see here, you know, the nucleus and the atypical cells. So the diagnosis finally was a primary intraocular lymphoma. So it was a tricky case. I'm sorry, I was telling Mahmoud that I didn't present this case for like 10 years, so I'm not get used to it. But still, it is a very impressive case because you can confront with so many diseases, and it was very opportune the lecture before this, because this is really a thing that you could find in your patients. Well, thank you.
Thank you very much, Mario, for enlightening us with important pearls while dealing with these tricky cases. Now I would like to invite Amila Husubek for her talk, and she is going to deliver her talk on update on uveitis.
Okay. Thank you very much for this invitation. Maybe somebody would remember, maybe some forgets a lot of these things, but I hope so that nobody will forget this friendly, the special social events in Pakistan. And I would like to say again, thank you for all our Pakistan colleagues, for all colleagues who will come. And finally, that's a life. That's a real life. Okay. Then I would like to update on uveitis. When you have our uveitis cases, the first thing is, okay, I will introduce steroids and I will resolve all of that. Okay, and check the patient, how close you have it, and it will be but sometimes it will not be the same. You all of us know what is uveitis and what does it mean really. And classification, you know, that is of anatomical disturb of eye, and that is what does it mean anterior, intermediate, posterior, and panuveitis, and what does it mean in this category that sudden insidious duration, course, and chronic is could be a problem also for us and for patients too. Etiological, you know that there could be infections, and you heard of our colleague, masquerade infections without and with systemic diseases. You know the clinical signs of anterior uveitis. What does it mean? That burning, redness, blood vision, irregular pupil headaches, eye pain, photophobia, or sensitivity to light, floaters, etc., etc. And Dr. Salman talking about causes of that it could be TB, Lyme, syphilis, back-chat lymphoma, as we saw it, sympathetic ophthalmia, sarcoidosis, a systemic disease, etc. Different there are factors in history and clinical exam. It could be unilateral, bilateral, acute, recurrent, chronic. It could be with high IOP, corneal precipitous, iris atrophy, corneal sensations, and always check the fundus. Corneal precipitous, you know how it is working, and we are starting with slit lamp exam, full blood count, high lobby, 27, syphilis serology, mantle test, quantiferon test, ELISA, Bartonella, etc. And for children also we have to include also NAS, urinary beta-2, microcarbonic, urine microscopic creatinine, etc. But is it a really paradigm for energy treatment, or it is our reality? What we have to avoid, that what does it mean at the time? First said that steroids, but we have to avoid high doses and treat it associated systemic disease, topical before local systemic therapy, early introduction of steroid sparing therapy, and treat our target. And how can we treat systemic fever? You know, it is systemic and non-systemic diseases, and respond and without the response on our treaty. Initial therapy, it started with topical steroids and psychoplastic, periocular steroids, triamcinolone acetate, severe inflammation with systemic steroids, and frequently or chronic, also you have to use methotrexate oral. Intermediate, you know what is that? And what was the causes of intermediate? That's tuberculosis, unfortunately, again is on the first place. We would forget tuberculosis, but unfortunately now in 21st century is again on the first place. Sarcoidosis, Lyme disease, toxoplasmosis, etc., etc. Of our clinical examination, we have to find the type of vitreous cells, peripheral chorioretinitis, peripheral vasculitis, you heard of Dr. Salman, and of course macular edema. What is our basic workup? That's for blood. I said CRP, syphilis serology, lysosome, quantiferon test, TBC, thorax, Röntgen, and sarcoidosis. And you know what is posterior uveitis and sign of it. And we are talking about vasculitis again. Dr. Salman had a very nice lecture about it, and I don't like to repeat it. And what is really my main aim was a case report. One day in our clinic came one very young boy, about 20, 21 years old, and he has blurred vision and he cannot see. Of course, after COVID period, it was so strange symptoms and other. And he was not anti-COVID vaccinated. He had just only hand motion in front of the right eye with normal intraocular flash. You can see right eye on the fundus camera. It seems like a lot of scars on the retina, and that is right eye. On the left eye, we have some beginning problems on the fundus, on the left eye, but it was a normal visual acuity. OCT on the right eye was this. You can see that problems on this, and what could be that a differential diagnosis, infectious or non-infectious posterior uveitis, white dot syndrome, acute posterior multifocal plaque with pigment epitheliopathy, SARS, or COVID infections, mascara, amyloidosis. And in laboratory results, we have a high CRP 9.9, ALT was 70, creatinine high, globulin, IgG, etc. But other laboratory results were in reference values. But when we use macrobiology testing, toxoplasmosa was positive, but IgG antibodies, Candida albicans also the same one, and the HIV test was negative, combo HIV test also was negative, quantiferon test was negative, sputum bacillus cough was negative, urinoculture of Mycobacterium tuberculosis was also negative. And what we should like to use a treatment, it's a triaxone twice a day per 1 gram and metronidazole and trimetoprim. In immunology testing, we also have a negative, but we found positive anti-amyloid antibodies. Higher typization was that only highly C07 positive. When we perform the Röntgen, you could see some pleural exudate on the left part. And we asked the pulmonology doctors, but they said it's nothing, don't worry about it. It is very small pleural exudate. But our patients couldn't see on the right eye. And when we performed serology test of SARS-CoV-2, it was negative, but EEG was very, very high positive. And cell-mediated immunity can play a major role in viral diseases, in which infected cells in the uveal and corneal tissue have virus-specific antigens on their surface. Cell-mediated immunity can cause specific tissue damage as acute retinal necrosis. And various immunoregulatory cytokines were detected in ocular fluid samples from patients with viral uveitis. Multiple studies were about how COVID-19 infections have effects on eye. Erika described clinical report of bilateral intermediate and posterior uveitis and a few weeks after diagnosis of COVID. Various forms of posterior uveitis have been observed following either acute COVID-19 infection or the COVID vaccine. Sposa reported a case of unilateral multifocal choroiditis. Voyager published a case of bilateral multifocal choroiditis within 1 week of COVID-19 vaccine. Today, our colleague George also reported the cases after COVID-19, not after vaccination, but after the disease. We consider that there are multiple questions and doubts about COVID-19 infections and influence on human body. This disease affects multiple organs as well as eyes too. We need multidisciplinary approach in resolving all difficulties that this illness bring with it. We consider multiple questions of that. And what is the most important before I said thank you, that COVID-19 is a more seriously disease than we could account up to now. And really, this young boy never can see again, only can emotions, and we are happy that he has good visual acuity on his left eye. Thanks a lot.
Thank you very much, Amila, for an excellent presentation and your words of wisdom. And now I would like to invite the last speaker of today's scientific session, Dr. Sohaib Malik. And we are privileged to have our co-chair finally with us, Mohammad Tawfiq, because he was busy with his talks in the other session.
My name is Dr. Shoaib Malik. I'm a consultant ophthalmologist and I have special interest in uveitic diseases. Today we are going to be talking about suprachoroidal space, the role of suprachoroidal injections in patients with uveitis. It's a potential space, and the inner border is marked by Bruch's membrane. The outer border is not very well marked. Most of it is collapsed at all times because of the intraocular pressure and the septa that are present there. The nominal thickness is 35 microns. It's just there so that during the accommodation, when the choroid moves, there is actually some movement between the sclera and the choroid. It has a role in IOP maintenance because of previous scleral outflow. Animal studies have shown that we can, pretty much inject 1 ml of drugs into the intraocular space and, get away with it. This is a study that I have been conducting at my own practice. It's an ongoing study in which I have been injecting suprachoroidal triamcinolone. It's an interventional and prospective study, and I aim to look at visual acuity, pressure, vitreous haze, and macular edema before the injection, and 4 weeks, 12 weeks, and 24 weeks after the injections. Right now, since it's an ongoing study, so I don't have complete data. I mean, I have the data, but it has not been compiled yet. So today we'll just be looking at 57 eyes in 37 patients, visual acuity, pressure, haze, macular edema in 15 patients only. That's the data that I have currently on one instance only, on week 4. So we took visual acuity by logMAR, Goldman 80 for IOP. For vitreous haze, we use the old scoring, the Sun working group. It's like a 30-year-old chart which we are still following. And for OCT, we had the SNO-based NITEC. So this is the frequency of different uveitic entities. This pointer is not working. Anyhow, we had anterior intermediate uveitis, intermediate panuveitis, 2 cases of leakage, and a total of 41 cases, 41 eyes actually. So we have omitted 16 eyes that I will tell in the next time. We use the standard 30 gauge needle. This was the dose. I always use a retrobulbar block for my patients because I have noticed that the immediate post-operative period of 12 to 24 hours, the patients are very uncomfortable if you do it in the topical. So if we give retrobulbar block, the patient just goes home happy and just goes off to sleep properly. This is the vitreous haze score that was used. The graphical representation of the same. So this graph was basically proposed in 2010, and it is a photographic scale, and it can be compared to the one presented by the Sun working group. And I have data on this one as well, but currently I have used the data for the previous Sun working group classification. So this is the result at 4 weeks. We had significant improvement in visual acuity in all the cases. This is logMAR. The pressure was more or less unchanged. Vitreous haze improved. Central macular thickness improved drastically. By the way, the cutoff value minimum patient had to have 330 microns of central macular thickness to be considered for this injection. The complications I encountered were intravitreal injection in one patient, and in two patients, the drug somehow did not go into the vitreous, but it actually came into the anterior chamber. And I had a discussion with my mentor, Professor Khurram Mirza. He's a VR surgeon, well known, and we were of the view that probably both of them were young patients. The anterior hyaloid face was preserved, and the crystals, they just kind of swooped into the anterior chamber between the lens and the iris, just a few crystals. For those, one of the patient was a non-steroid responder. She got already pseudophakic. She had anterior uveitis as well, so I just let those crystals be in the anterior chamber. I was like, there's an added advantage. But for another patient, the second one, she was not a steroid responder, but she was phakic. So I had to go into the anterior chamber and remove those crystals because I did not want the cataract to progress. All these patients were obviously not included in the study. Intraocular pressure, there was no intraocular pressure, right? But when we're giving the suprachoroidal space it's very limited. So if you give even 100 microliters of fluid, the patient is gonna feel a lot of pain. That night is gonna be uncomfortable. So what I do is I just give the patient 500 mg acetylcholine tablets, one dose start, so the patient is really happy, along with an NSAID, probably like Caflam. I also had 16 eyes in patients who were on immunomodulation therapy. They were on immunosuppressive therapy, but still they developed a flare. So in those cases, this is the distribution. 4 eyes with Behçet's, an eye with leakage. 3 eyes were on mycophenolate, 5 on methotrexate, and 8 eyes were on TNF-alpha inhibitors. These are biologics that we were using. So when I gave them these injections, they responded really well. And the main advantage was that we did not need to increase the systemic dose or frequency of those medications. I mean, you can give a patient Cellcept, mycophenolate, or infliximab and not expect to have systemic side effects for that patient. So without increasing the dose and frequency, if we could give an injection to the patient and the patient responded well in one eye, that was a win-win situation for me and the patient both. And we can see that these results are comparable to the patients in which there is no immunosuppression therapy. The p-value in intraocular pressure, I'm not sure if it's right or wrong. I mean, it's 0.6. I think it's wrong. I need to have a word with my stats guy because I don't think that this could be published. Anyhow. So I have a lot of patients whom I inject with suprachoroidal injection, but I need to have a cutoff frequency for these patients. And the question is, when should I switch the patients from suprachoroidal injections to systemic immunomodulation therapy? I mean, there is no literature or data. I have my own clue going on, and I say that if any patient requires more than 3 suprachoroidal injections in an eye, I just stop giving them injections and switch to immunomodulation therapy. Conversely, there are patients who don't want to be on immunosuppression and they're happy with injections. They actually opt for injections. So if I have patients who have bilateral pan-uveitis and they don't want to be on TNF-alpha inhibitors or immunomodulation therapy, so for them I have to offer this. But as a rule of thumb for myself, I don't know, maybe in coming years I'd be able to publish this data that more than 3 injections per year, just switch to immunomodulation therapy. So the main advantage of this space is that the drug goes to the place where it's supposed to be. This is a section of a porcine eye in which fluorescent was injected, and you can see that it just does not go into the anterior chamber at all. It just stops dead at the ciliary body, and it's amazing because it's not going to give you those side effects. And in animal models, these injections, plasma levels negligible, vitreous humor very less, very high in the choroid artery, sclera, and retina, and none in aqueous. This is extremely, extremely important. That's why we're not getting any side effects. We're not getting raised intraocular pressure. We're not getting any cataract. Compare this to intravitreal injections. same, a lot of drug just goes into the choroid. Not the only advantage into a vitreal injection is there's just the depot. The depot form, it can just stay there for longer, but all the anti-VEGF and steroids, they have their life of around 2-3 months at max. Suprachoroidal stays there for 3 months straight away. Nothing. I mean, I have patients who are like, they just call me and they're like, hey doc, I think it's been 3 months and I'm getting those floaters. So should I come? I was like, yes, you become really smart. And you repeat the injection. Yeah, then after 3 months, I don't need to, but there are patients. I mean, for some patients, I don't need to inject them for a year or so. I mean, I have a lot of patients who never, return to me in the last 2-3 years. So,
but after how long you can repeat
sir,
it?
I have not seen a single patient who needed a second injection before 3 months. That's. I mean, it's amazing. So this Peachtree trial, this was conducted. The main device for suprachoroidal with the FDA device was done on this study, and the data showed that there was no worsening cataract or raised IOP in patients who received suprachoroidal injection compared with the control group. So I think this is basically industry changing. So in Pakistan, we have to look at the cost. I mean, it's a big thing. People can't afford immunologics. They can't afford mycophenolate. It's expensive, So this ClearSight device costs $2,000. Only FDA approved device in USA. Previously, Ozurdex was used a lot in US when I was there. It costs around $1,500. Just the device, doesn't include the hospital costs. And then we have the Retisert implant, costs $20,000 US. I mean, it's not feasible to have this in Pakistan. And if you compare Ozurdex with Retisert, I mean, you're gonna invariably get raised IOP, filtration surgery for uncontrolled glaucoma, cataract surgery, and for Ozurdex, the duration is 3 to 6 months. That's the industry claims to be 6 months, but inflammation usually returns in 3 months. Retisert, I mean, it does wonders for 2 years, but I don't think that we're ever going to have that in Pakistan. So the main chairperson who was overseeing the suprachoroidal clinical trials for Deborah Goldstein, she's chair at University of Chicago. I met her. She had been presenting. She was comparing ClearSight suprachoroidal with subtenon injections, and I asked her that how do you compare suprachoroidal with Ozurdex, and she was like, we can't do that. But how are you planning to do? I was like, we're just gonna spend probably $20, $30, $50, and we're gonna inject the patients with suprachoroidal injection. So practically, Ozurdex is just going to be obsolete. That's what I think. I mean, sorry to alert. I mean, we've never had it. When I came back to Pakistan for starting my practice, I really wanted to have Ozurdex in Pakistan, but we could not because it was expensive. So probably if we go for suprachoroidal injections, so it's just going to replace all of these. So I say that suprachoroidal space is a potential space, but it's a space with a lot of potential. Thank you. Any questions, please?
Thank you very much, Sohail, for your exceptional effort. And what we can see, we have seen very encouraging results of suprachoroidal cataract in case of uveitis and in case of diabetic macular edema. You can see a miracle result because it's cost effective. And there was a question from Akram Sahab. He's a very senior ophthalmologist in Lahore. What should be the minimum timeline where we can repeat suprachoroidal cataract? If anybody can share his views, what should be the minimum timeline if it is required in case we can repeat suprachoroidal triamcinolone and cataract?
I don't know if I get this.
There's no difference between the timing for suprachoroidal if the effect is gone away, you need to repeat it.
So minimum, I think that there should be 3 months.
3 months.
3 months.
I've not seen inflammation return before 3 months.
But if it is retained before 3
Yes,
months,
you can repeat it. You can just repeat that. But I mean, I've seen 2 patients. They've had retinal detachment. So initially, I was probably scared that maybe it was because of. But they had like very bad uveitis. So it was traction and retinogenous detachment. So we had to go for that. I mean, it had good prognosis, but then again, it's an invasive thing. You're going in the eye, but I think that since you're in the vascular layer, so it's very safe in terms of infection. Just don't go too deep.
I have a question. I mean, why have we reached the stage of incriminating intravitreal triamcinolone, although it has been so effective? Intravitreal triamcinolone is very cheap, it's available, it has been being used, but I don't know what is happening that now everybody is avoiding to talk about triamcinolone in the vitreous. Why is that?
So
Is
there
this
is
the companies?
No, it's not the companies. There's a huge trial. It's called the MERIT trial. They compared Ozurdex with Subtinon and intravitreal triamcinolone. So if you're just my attending, Dr. Vitali, he has done a lot of work in uveitis. He used to say that you give 3 intravitreal triamcinolone, the patient's gonna come back with a cataract. That's for sure.
If he is,
Pseudophakic and also raised IOP. So if you give them a lot of intravitreal triamcinolone, they're just gonna get.
Patient will come with glaucoma after 3 months.
That's for sure.
Yeah, excuse me, but
Ozurdex is the same.
triamcinolone is not
Absolutely.
the reason for cataract.
Okay.
Maybe somebody touched
Well,
the
I just want to raise this issue. I mean, triamcinolone is still effective and it's in use, and whether you inject it in the supracoroidal space and even inject it in the intravitreal space, it is quite effective. It's available, and don't forget it.
Amila, would you like to add some more? Because here in all parts of, you can say, subcontinent, people are afraid of giving triamcinolone because it can cause cataract. You can enlighten us more in this regard?
Okay, I would like to explain that it's not problem in triamcinolone. Problem is our attitude about treatment, really. Triamcinolone is a great, and it is very helpful for these cases.
It's also going to give the
And
patient a clumpy vitreous,
we
you know.
have not to have to avoid it. We have to use it. But if you have a cataract, triamcinolone is not the reason for cataract. Maybe somebody who put injection touch lens. That is the reason, not triamcinolone, not
Triamcinolone on the long term, we know that steroids will but so what?
So what?
So what? I mean, cataract surgery is such a successful surgery anyway. And those euphytic patients will develop cataract
You have
anyway.
healthy patients with 45 years old pushing you to get operated with premium lenses, and now we are at this.
Well, the only thing is, I mean, you have to be flexible. You have to be, well, I totally applaud you. Thank you very much for the very nice presentation.
No, this is a very healthy discussion indeed.
So, I mean, be flexible, use whatever, and
Sir, I have been working with Professor Khurram Mirza. If you give suprachoroidal triamcinolone in on cases, then the retina becomes less brittle because you're eventually going to go in there and remove the vitreous, put in silicone oil. So if the patients had been given suprachoroidal steroids, their retina becomes less brittle because you know when we go into the vitreous and do vitrectomy, all every tissue is fragile. You know, you start from the zonules to the retina. So only in those cases, not in probably CMV retinitis or any other case. Just these cases.
So just one more question. You did mention that these patients that you were giving these triamcinolone acetate were also on immunosuppressives.
Out of 57, 16 eyes were.
So they were. So in these patients, do you think that you had to give, how often did you have to repeat or give this injection in those patients?
So for probably 1 eye per annum.
And did you have to increase the dose of the immunosuppressives in that
No,
case?
that's the good
So
thing.
you kept the immunosuppressives at that
The
and you just
frequency
gave
for let's
that.
say infliximab was like 4 weeks. So we just kept it there.
And you just gave that. And you had to repeat it just once.
So, Amila, we have to be flexible as regard of cataract after triamcinolone. What about glaucoma? Because there are a lot of studies supporting that you finally end up with glaucoma after 3 months of injecting triamcinolone.
What about glaucoma?
Glaucoma, because we will have to start anti-glaucoma Our patient may
Eye
end up.
drops, yes, eye drops. We are starting with eye drops. If it is not okay, we could perform LASIK trabeculoplasty. Yes.
So you deal with glaucoma as if you deal with a cataract. If you have a cataract,
No,
if you have a
it
glaucoma.
is not a problem. We could resolve for a few minutes. Cataract or glaucoma, it is not a big problem. The problem is in uveitis. To resolve that, because they will see with glaucoma whatever we use.
Yeah.
So we're honored and we're grateful on behalf of Ophthalmological Society of Pakistan Lahore branch for being with us. For our foreign speakers, Muhammad Suleiman, Muhammad Tawfiq, Amila, and Mario. And it was indeed a great pleasure to have all of you with us. And thank you very much.
Thank you.
Thank you very much.